All right. Hello, everyone. And thank you for being here for today's talk about reimbursement for the life participation approach to aphasia. My name is Michelle Armour. I will be your moderator today. And I had the pleasure of organizing this talk with Melinda Corwin and Nina Simmons-Mackey. And the three of us are thrilled to introduce our speakers, Jody Morgan, Fabi Hirsch-Cruz, Becky Kayam, and Claire Orzak. All of them will introduce themselves more thoroughly here in just a few minutes. But we did want to, before we hear from our speakers, just mention that, of course, today's talk is being hosted by Aphasia Access. If you are not already a member of Aphasia Access, we hope you do consider joining us as part of this fabulous organization. The goal of Aphasia Access is really to provide cooperative exchange of programming knowledge, research collaboration, and best practices, and provide resources to members to further the use of life participation approach to aphasia. So let's talk about life participation approach to aphasia briefly, in case there are any newer clinicians on the call today or anyone who hasn't used it yet in practice. The life participation approach to aphasia, generally speaking, is of course a statement of values that provides clinicians a guide to use to promote goals for increased participation for individuals living with aphasia. So it really supports the fact that we need to put our patients with aphasia at the center of all care and decision making, and really focus on what their personal participation goals are. We use AFROM as a guide when implementing LPAA, and you can see AFROM here in the image, and really supporting the fact that LPAA should be used, can and should be used across all treatment settings and clinical environments. And we really hope that today's talk can show you realistically how we can make that happen. So that's what brings us here today, is the ever daunting topic of reimbursement. We are all faced with challenges in reimbursement, and I think we can all relate to how this image is here. We've all felt like this at one point or another in our clinical practice. So what brings us here today is to share some experiences and creative solutions to get past these obstacles of reimbursement so that we can provide the care that we really want to provide and know what's best for our patients with aphasia. So with that in mind, though, we do just have a brief disclaimer. The information in this panel is strictly shared experience. We are only referring to the United States when we're talking about reimbursement today. And of course, then knowing that reimbursement can be different across states, across facilities. So we really want to emphasize that all decision-making in terms of reimbursement really should be consulted with your employer or the relevant payer. But with that being said, we hope that our experiences and insights can help you provide the quality care that we want to provide to our patients with aphasia. So without further ado, I am going to pass it over to our first panelist today, Jody Morgan. Jody?
Hi there. Thank you, Michelle. I am really excited to be here with all of you today. And we have a phenomenal panel. And I think it's going to be great because we're all going to kind of give some different viewpoints across all continuums of care, give you some ideas, hopefully some inspiration, and hopefully make the term reimbursement and LPAA a little less daunting, so you won't throw your head on the desk like the gal in the picture there. So I am Jody Morgan. I'm Brooks Rehab Aphasia Center co-founder and manager. I'm also a clinical assistant professor at Jacksonville University. And I just have to say it's beautiful here. It's about 70 degrees and sunny, so I just kind of wanted to throw that in before I started. All right, next slide. So a little bit about our unique setting. We want to talk about different settings. We know we have folks from skilled nursing, from acute care, from academia, from all home health, all different settings. Life participation, as Michelle mentioned earlier, can and should be implemented in all aspects from the onset of care with somebody with aphasia. So just to make a little clearer picture, I work for Brooks. My aphasia center is funded completely by Brooks. So we're a different model. We're actually a really, really big nonprofit hospital organization. We're actually the third largest independent rehab hospital in the US. but we still implement LPAA at all continuums of our care. I'm going to talk primarily about our Aphasia Center and just give you an idea how you can implement and be reimbursed for LPAA. Our particular center opened in 2016 after I won a crowdsourcing idea. So they pitched an idea at our hospital. I did a lot of work. We won the idea because even in our large hospital organization, there really wasn't a lot of LPAA and opportunities for people with aphasia. And I saw that missing link. And so we pitched the idea, but I had to really talk to my board, talk to administrators to get this funded. But we opened in 2016, and that's just a little brief history about our source of funding. All systems of care, and I really want to focus on the statement again that LPAA must start at onset of aphasia and continue until consumers and providers agree that targeted life enhancement changes have occurred. This is just so important to think about because everyone on this call can have the opportunity and should have the opportunity to implement LPAA as soon as the person develops or has aphasia. This is our continuum of care at Brooks. So we have rehab hospitals, skilled nursing facilities, home health care. We have assisted living, memory care, outpatient physician practices. And LPAA now is really implemented in all systems of our care. I am in charge of the Aphasia Center, which you can see is under our community programs and services. But remembering under that umbrella, we also have things like adaptive sports and brain injury clubhouse, because not necessarily is the changing of thinking that our goals as speech pathologists might be different, of course, and are different than our friends with aphasia. So a lot of times, sometimes someone might come to me and their only goal might be, I want to participate in sports again or something like that. So thinking, remembering life participation approach to aphasia, their goals might not necessarily be strictly communication-based. And just a little bit more about that. Our program under community health and wellness, our particular center is under that community health and wellness, but we also have all sorts of opportunity for people after they've been discharged from the hospital. Some of our members, you can see from the photos, really they have a goal of, I want to get back to something like archery. So we have like adaptive archery and bowling and surfing. The picture on the far left is a group of us that were going to a 5K walk for American Heart Association. So just thinking about how LPAA can fit into your community and all the different opportunities, I'm hoping thinking about the different things that you can do will inspire and think about how are there niches, how are there ways that I can help people with aphasia in all aspects of their recovery. Little bit specific about the reimbursement at our center, our particular center. We are a community-based center, and we're open 4 days a week from 9 till 2. The way we do things is we're based on a sliding scale fee, and people pay out of pocket. There's no insurance involved with that at all. And if members don't have funds, we have a scholarship fund and through our endowment program that pays for people. So again, another value of LPAA is everyone is entitled to service and all continuums of that care. And so we want to make sure that if someone doesn't have the funds, that we do have the scholarship monies available for them. Again, we are not outpatient, although as you saw from the previous slide, that's available in our Brooks system. So sometimes some of our folks will get outpatient therapy 2 days a week and then come to our center for conversation groups, other activities as well. And then we do offer Zoom groups, and our particular Zoom groups are available at no cost to reach all individuals who maybe don't have transportation to our center or are unable to come into our center. And then I really wanted to take a minute to talk about resources because I think this is really important. My other wonderful panelists are going to talk about some of the very specific things about reimbursement, but Resources are extremely important, I think, in both developing an aphasia center or developing a group or just promoting life participation based services wherever you are. These were 4 things that were very fundamental, were very pivotal in helping me understand LPAA, helping me live and breathe it, and helping me see how important it is to changing people's lives. It is aphasia in North America, I think, is one of the very, very phenomenal resources that we offer through Aphasia Access by Dr. Nina Simmons-Mackey. This has been so powerful in talking to my board, talking to other folks, not even necessarily speech pathologists, mental health counselors, physical therapists, occupational therapists, nurses. Some of the facts and statistics in this have been very instrumental in helping others interdisciplinary understand LPA and implement it into their care. It talks about service gaps. I highly recommend it. It's over 100 pages full of wonderful facts and just some concepts in aphasia. The other resource that I would recommend is, again, another Aphasia Access. It's the academic modules, and it's listed under resources. So you just click resources, and a lot of clinicians that I've shared this with said, oh, I didn't even know that we had that. Or they'll say, I thought it was academic, so I thought it was just for professors. But there's actually 4 modules on there that are fantastic in helping with reimbursement, with ideas. There's some great goals. There's an assessment module, an LPAA module, a treatment module, and they really kind of guide you through the process and kind of wrap your brain around reimbursement in general. So I wanted to share that. And then aphasia centers, in the life participation approach, Dr. Roberta Ellman's article, Paradigm Shift, I thought was really, really helpful, especially with some of my administrations and doctors explaining life participation approach to aphasia to them. And then finally, this last one, I love this book. I have it all highlighted and everything. The new book out by Dr. Audrey Holland and Dr. Roberta Ellman. I think it's very helpful in understanding concepts of LPAA and then therefore understanding reimbursement and how best that you can be reimbursed for those services. So I hope I got everything in. I know we're going to have some questions and answers at the end. And I'm going to turn it over to my friend Fabi from Friends of Aphasia, who's wonderful, and she'll talk to you a little bit more about the meat and potatoes of reimbursement.
Thanks, Jody. Hi, I'm Fabi Hirsch-Cruz. I am with the nonprofit Friends of Aphasia here in Tucson, Arizona, and we're going to hit 87 degrees today, which is not really good for like beginning of March. So yeah, Michelle, you can go on. So I wanted to share just a little bit about my work experience. I've worked in a number of different settings. I've worked as a speech pathologist in skilled nursing, in a university clinic, aphasia clinic setting, a hospital-based aphasia program. But currently, I'm in 2 settings. I am in my private practice, which is Saguaro Center for Speech and Language, and I've had that for almost 10 years. It is a solo provider private practice and originally included the Aphasia Center of Tucson, but more recently founded or co-founded Friends of Aphasia, and the Aphasia Center of Tucson is now part of Friends of Aphasia, and we've had that now in place for 4 years. So I'll talk today primarily about my current experience, because this is where I've had the most exposure to the actual reimbursement part. So my private practice and my nonprofit community-based aphasia center in Friends of Aphasia. So first, my private practice, I mentioned I'm a solo provider, so it's just me. So my experience might be very different from others who are in larger practices, and I would love to hear how you're managing that, because when it's just me, if things don't work out, I don't have to stress too much about it. So I'm very excited for the Q&A. I am credentialed with, I am credentialed with many insurance companies, and there are, I guess, pros and cons to that. Medicare, Blue Cross Blue Shield, I've listed some of the biggies here, United, Humana, I would say over 10 insurance companies that I'm credentialed with. I do want to add a disclaimer. I have cut back quite a bit on my private practice in the last 2 years. Part of it was COVID, part of it was just some ongoing frustrations with insurance, and part of it is that the nonprofit is really growing, and that's taking more and more of my time. So first, the private practice piece. So the insurance and the life participation approach. I am a very strong believer that our health insurance should pay for speech therapy services. Your employer and you, however your insurance works, you're paying for health insurance, and it shouldn't just cover returning to being able to walk again or having surgery. Speech therapy should be a benefit that you receive from your insurance provider. So that being said, many of you, I think, would agree that life participation goals for aphasia are not short-term goals. Typically, they're really long-term. They require a great deal of therapy. And I feel like I've been very fortunate in securing reimbursement for long-term services, so for years of therapy. And I just wanted to touch on 2 parts, and I look forward to talking more about this too in the Q&A. The 2 pieces are documentation and billing. And Becky and Claire are going to go into a lot more detail about documentation. So I just wanted to share a few things that I keep in mind for my own documentation. I always include a combination of readily measurable objective information as well as the functional life participation information. And I do that both for my goals, my progress reports, my care plans, because you never know who is going to be reviewing. And I feel like some reviewers are much more numbers oriented, much more objectively focused, and they, I think, don't really care so much about those real kind of warm, fuzzy life goals that I think are such a critical part of therapy. But I think there are reviewers who do respond to that. So I do that to take everybody's view into account, because I feel like you just never know who is going to be reviewing your reports. And I always add something about safety. Maybe it's the cynic in me, but insurance companies, it's about money. They aren't looking for ways to give you more. They're looking for ways to give you less. So because it's so money focused, I feel like incorporating an element of safety, so that, as for the example here, if a patient miscommunicates information to the physician, what could happen that could impact the insurer? Could there be further medical complications that are going to require more money output on their part? Could it ultimately result in a lawsuit that they're going to have to manage? So I think that safety piece is important. And again, it's just a little dependent on the reviewer as well. The other piece I wanted to talk about just briefly is billing. So using, for example, for Medicare, the KX modifier, I always extend beyond the what used to be the therapy cap and is now the KX modifier threshold. I always extend beyond those that threshold, and using your modifiers appropriately, I think, is really important. And I think recognizing that it's not a great system that we have for reimbursement, and that there are times where you won't get reimbursed and you can get payback notices years later. To recognize that those are problems, complications that you'll have to deal with, will hopefully make things, especially if you're starting out, knowing that a little bit easier. Sure. All right, and so switching over now to our Aphasia Center, the Aphasia Center of Tucson, we have 3 programs. We have our Aphasia Group Program, our CAST program, and our Tech to Talk program. So I'll talk about the CAST program and our Tech to Talk program just briefly, but focus on our aphasia groups. So our CAST program stands for Community-Based Aphasia Support Team program. It's based on Maura Silverman's CST program. It's really a grassroots, community-based intensive program, and that is completely funded by donors, but it is tiny. We see one person at a time in that program. And then we have a Tech to Talk program, which is our technology loaner program, and that also is funded completely by donations. We have donations from IBM and from some COVID grant funding for some iPads. So our aphasia group program, this is, I think, similar to Jody's in that it is tuition based. And we do have a system in place to provide scholarship money for folks who cannot afford the full tuition, although we do keep it very low. But we would never turn anyone away for inability to pay, although we do insist that people pay a portion so that they definitely have skin in the game. Oh, one back. Yeah, so our Aphasia Center, our Aphasia Group program, I really feel is a wonderful complement to an extension of individual therapy. So I don't necessarily feel like, oh, you do individual and then you progress to group when all the reimbursement runs out for individual therapy. I think having those two at the same time has worked, in my opinion, really beautifully. And having the groups, we really get to address a lot of the considerations of life participation, including ongoing services and just providing a sense of community for our group members to practice their skills and to re-engage in their lives. We do, like I mentioned, keep tuition very low and have partial scholarship funding when needed. So I'm just going to wrap up with some lessons learned. Aphasia rehabilitation, for the most part, takes a long time, and having that combination of the private practice and the Aphasia Center has really allowed me to see my patients or group members for long periods of time, and that's been critical to helping people maximize life participation. It is not easy. I have had many days like that image earlier, banging my head against my desk, crying after talking to reps, getting denials, requests for recoupment years after services were provided. And just wanted to wrap up with, it's certainly not all negative, so we'll end on a more positive note, but some words of wisdom that just I thought through, especially for folks who are just maybe starting out. Finding a good biller has been critical. I had my first biller was not great, very difficult. Recognizing, I think from the get-go, that reimbursement will be a struggle, probably, and just knowing that. And for me, just maintaining my focus on what I love, which is the clinical piece. I can't say enough about how much I love what I do in the clinic. And so I keep all like the thank you notes I receive from family members and from group members and my patients. I keep all of those together in a binder, because when I have bad days, and I have a lot of them, I have something to look at and just remember why I do this, and I carry on. So thanks so much. Oh, and I'm going to turn it over now to Becky.
Okay. Yep, we'll turn it over to Becky and Claire now, who will be presenting together.
Thank you. So everyone, hi, I am Becky Kayum. I am in the Chicago area, and I'm the president of Memory Care Corporation. We're an outpatient rehabilitation agency, and we provide skilled Medicare Part B and insurance reimbursable therapy services here in Chicago. And I'm also the owner of Cognitive Concierge. This is a new digital health and wellness company. We offer a range of services. Oh, next slide.
Hi, everybody. I'm Claire Orzak. I'm a speech language pathologist first, but also the regional director of Memory Care Corporation. So I manage all aspects of the agency, including reimbursement, and also have the pleasure of providing some treatment to the clients that we serve. And just some of my past experience is that I have worked for large, big box, prominent geriatric therapy companies, overseeing the operations in multiple direct bill or outpatient therapy departments within skilled nursing facilities, and then also overseeing the provision of contractual agreements with the home health agencies that we worked with in those direct bill communities. So I think we should talk about the barriers first, because we do know that there are some when it comes to provision of LPAA. First and foremost, really, it's the lack of exposure and education on how to apply it across the settings. And I think I'd really like to speak directly to our educators out there that not just in the clinical practicums, but in the classroom of reviewing some of these items so that our students and our new clinicians can be solution minded from the get-go is so important, because you don't always get to see some of those little ins and outs or really understand the idiosyncrasies of the real world until you get there. So another one would be time constraints. How much time do you have to work with the client? Visit constraints. So sometimes because of the payer source, if you're in a skilled nursing facility, you may only have 30 minutes. Other times you could have 45 minutes to an hour. All these things change year by year. Productivity expectations. I don't think I have to talk too much about them, although some companies seem to be a little bit more ethical with them as of late, which is positive. And then really one that's just so important is the electronic health record, or the EHR. So often, at least for the one that we have as Memory Care Corporation, it has pre-populated fields in which the clinician can build goals. And I've used the same EHR system when I worked for the larger therapy company, so I know it's a well-known one. The problem with that is in those pre-populated fields, they're all impairment based. There is something to be said that as a skilled SLP, we do provide interventions for impairment-based situations. However, when it comes to LPAA, we're really looking for that person-centered approach and documentation. So we don't want those generic goals. We want novel narratives. So best practices, I review this with every single one of the clinicians on our team to remind everybody that Medicare and insurance will cover LPAA focused services and plans of care. But you really, again, like I said before, you've got to focus on that person-centered documentation. First and foremost, you can do that by completing a person-directed interview to identify what the client's concerns are, what their frustrations, what are their goals. And then your assessment within that evaluation will be able to further determine how those deficits can be measured and how we can apply them and allow those people to meet their goals. Again, I'm a broken record with my team. Novel narratives. I really want people to write down what they're seeing, not just press some buttons to build some information. So I created this narrative within the reason for referral or the chief complaint. It's of my personal opinion and my years of auditing that the patient history and report is extremely crucial to really knock it out of the park in the beginning of the evaluation. So if you do get audited, they can understand you're telling the story of the client. So in this particular, I'm not going to read it directly, but for us, we always explain the situation. In this one, it's a telehealth evaluation. We explain who we were referred by, or who gave us the referral, some of the medical information, the review of the notes, and then the meat and potatoes of the situation. So the client, if there's a care partner available, and what their main goals and hopes are within the plan of care, what their frustrations are, and how we're going to target that. Excuse me. And I love just having my clinicians list it out, because then it's really straightforward that these are the areas that we're going to work on. And of course, they all relate to something that we can provide as an SLP: expressive deficits, receptive deficits, reading comprehension deficits. So finally, then, as I've kind of alluded to this entire time, you accomplish all of this with a client-directed motivational interview in the process. So as much as we try for the clients we serve, we always encourage a care partner to be participating, whether it's within our private practice in the telehealth, or if it's within one of the assisted living memory care communities that we work in. We always try to get that additional information so we can see this as a holistic situation. Taking the time as much as you can to build rapport and have that trusting relationship there, listening to the person's history and the story. And then I always ask, I've got 2 questions here, but I always like to ask 3 questions in the evaluation. What are your daily challenges? What's frustrating you? And then also, what would you like to accomplish with working with me? We always want to be as transparent as possible. So we love to write out a list of those challenges as we're hearing them during that motivational interview, show them and share them with the client, and then let them know that the plan of care that we're going to create is going to follow what those frustrations are. Becky, you can explain some more.
Absolutely. So just in thinking about best practices for, again, goal writing, it's so important that you're writing goals that really focus on things and activities that are important to that person that you've identified in that motivational interview. And of course, we're including the evidence-based approaches, the accuracy, the level of cueing provided. So as Fabi mentioned, it's really blending that really skilled approach in addition to what's the purpose, right? What's important to your client. Next slide. So you might be thinking, well, I'm trying to write these goals, these novel goals in my electronic health record system, and it just takes forever. It's so simple just to use the click, build these impairment-based goals, right? Exercises we're going to do. Let's do some generative naming tasks. I don't have time to write these other goals. And a way to get around that is working with your team, your rehab manager, create a bank of goals that you have on your desktop, even in a Word document. That's what we do at Memory Care. And then you can copy and paste those directly into the EHR. And then you're just tweaking the goal for your individual client. So just a quick example, the first goal here is someone who wants to talk about their garden in daily conversations. Secondly, preparing a favorite snack and working on comprehension strategies. And lastly, using communication strategies to participate in a group in more of a facility setting. And so if you copy and pasted, for example, the garden goal, all you'd have to do is change it to football, right? If someone's interested in that topic instead. So that's just one suggestion for increasing efficiency in LPAA goal writing. Next slide. So let's talk about some reimbursement myths really quickly. So the first one is that reimbursement is based upon a standardized measure. This is actually false. Standardized test scores are not required for reimbursement. Again, Claire talked about a detailed narrative, and those person-centered functional goals are actually what's going to demonstrate progress. And if your rehab center is requiring you to have use a standardized test, of course you could quickly give the MOCA or the SLUMS, but don't spend a lot of time on that. You're quickly, really going over that, but you're starting with that motivational interview to build rapport with your client. Second myth, that LPAA goals lack skill, so therefore they're not reimbursable. And we've talked about you're including the accuracy, the level of cueing, and the evidence-based approaches in those goals. So therefore, they actually are very skilled and reimbursable. Just some myths about Medicare reimbursement. Perhaps there's some of you out there that have a private practice or you run a university clinic, but you say, well, I don't accept Medicare. I'm going to ask my clients to pay privately instead for these skilled services. And that's false. You can't do that. Medicare actually prohibits any therapist from billing patients privately if they're eligible over 65 for Medicare. If it's an unskilled, non-reimbursable service, like coaching or something like that, then you could, but otherwise that is prohibited. And then lastly, you might say, well, I can't continue to treat my client, after they've reached their annual Medicare threshold. And so really there is a medical review threshold, meaning you're passing $3,000 of billed services, and claims can be reviewed, but certainly you can go past that threshold, as Fabi mentioned earlier. Briefly, let's talk about progressive deficits and reimbursement. So you're working with someone who has primary progressive aphasia or Alzheimer's dementia. How do we demonstrate progress? This is an example where LPAA approaches are absolutely critical in demonstrating progress. And so think about a standardized test for this population. It's not going to show progress, most likely, right? Because it's impairment based. And if your client actually received a consistent score over time in a progressive condition, that's actually showing progress for them. So you really may need to shift your treatment approach if you're finding that you're discharging people due to, quote, a lack of progress. Next slide. So continuing on progressive conditions, well, okay, how do I demonstrate progress then? And so again, I know we're harping on this, but provide that detailed narrative, think about those goals. But other important points are that you've really got to engage the care partner in all of your sessions if possible, because if someone's declining over time, you're going to be increasing that care partner cueing and assistance, and that's how you'll meet those goals. You'll be able to meet their target accuracy, but you're going to have to increase the level of support to get there. If you're saying, well, they can't participate, they live somewhere else in another state, they never come to visit, try using video conferencing or loop them in on a conference call so they can be a part of that session. Incorporate, leave them a note that explains what you've worked on that session to loop them in as well. Another thing is really the importance of documenting use of compensatory strategies that you're using, AAC. So instead of just thinking about, standard language and memory exercises, using a workbook, the compensatory strategies in this population and stroke-induced aphasia, of course, as well, can really help to demonstrate progress. And lastly, people with progressive conditions don't graduate from speech-language therapy. You really need to educate them, hey, as you're continuing to experience new challenges, please come back and tell us so we can pick you back up again on skilled therapy. Next slide. So to wrap up on a positive note, we all need to be advocates for use of the life participation approach for aphasia in our settings. The change is going to happen from the bottom up. We can't expect these large rehab companies to make a change in use of LPAA from the bottom or from the top down. We have to challenge the status quo. All of us can do this. We have to look at each person individually. We have to be confident that our documentation can support the use of LPAA approaches. And how creative can you be with a short period of time, right? If you don't have a lot of time to work with that person, how can you creatively engage those care partners, as we talked about before? And if you're getting some pushback on this, speak with your rehab manager, have it escalated. Let them know, show them that LPAA is best practice for life participation, outcomes, and ensuring that your therapy is, skilled. Explain to them how documentation can support reimbursement. And if your company is really focused on profits and productivity, we'll let them know from a financial standpoint. A lot of times using a life participation approach can actually help you to extend the longevity of really seeing that person on therapy caseload, because you're continuing to work on more things that are important to them over time.
Great. Thank you so much. We wanted to take this time to discuss all of this because I see in the chat and the question and answer, there's already a lot coming in. So that's what we really wanted to spend the remaining time on. I want to pose our first question to Jody. Jody, do you have any advice in talking to hospital boards, managerial staff about initiating and funding an LPAA program within a healthcare system?
Yeah, I would just say really, it's so important and it's so powerful to educate yourself about LPAA, and there's a lot of wonderful resources out there. Don't be afraid to talk to some of the wonderful colleagues here in Aphasia Access and others. That's how I really learned so much from some of the wonderful colleagues. And then just really speak with your heart that you have the facts. It was really amazing that I worked for such a big organization and how we had so many missing gaps for people with aphasia. You can implement it from the moment of onset and be creative. And there's a lot of resources and facts out there that can help support. A lot of my administration think money and think numbers, but there's a lot of statistics out there that they can't deny that really can help support people with aphasia.
That's great. Thank you. A question in our Q&A box here, and this goes for everyone, I think. How many people are in your LPAA groups, and does anyone bill for group therapy? Jody, do you want to start? Can you all hear me now? I think we had a little internet taboo there. Sorry.
Yeah, sorry. I am so sorry. It glitched out and you were frozen.
Okay.
And I couldn't hear the question. I'm so sorry.
So I apologize. The question is, how many people are in everyone's LPAA groups, and does anyone bill for group therapy?
Okay. Well, if you want me to go ahead and start, is it okay?
Sure.
So we have for example, our LPAA Zoom groups. It depends on the group. So we offer 5 a week, and we do not bill for those groups. Those are just Zoom groups that we offer. And we have anywhere from 5 to sometimes, close to 20, but usually it's about 5 to 11 on our Zoom groups. In our in-person groups, I wanted to clarify. I saw Robin had asked a question about the daily cost. Our groups are $10 to $40 per day, but we have groups from 9 a.m. to 2 p.m. So that's per day. It's $10 to $40. And our groups, our members, we used to have a lot more pre-COVID, but we have probably on average about 12 people with aphasia per day on those groups.
That's great. And Claire, can you speak at all to billing for a group therapy code for LPAA groups?
We do not provide groups at this time. We just do single individual interventions.
Excellent. Gabby?
Yeah, Michelle, I can speak to that from our perspective. So for our groups, we're currently all virtual, still on Zoom. We're hoping for a spring return to in-person groups. So on Zoom, we have 2 groups, 2 days a week, each for an hour and a half. It's very different when we're in person. And so we typically have about 15 participants who join at any one time, and we have a community building time where we do humor and movie reviews so everyone gets to still see each other. And then we use the breakout room function in Zoom to break out into smaller groups for the structured conversation. And we typically have 3 or 4 group members in each of those groups. With respect to billing, we charge tuition, and I know this is like a tricky thing. Our groups are led primarily by trained volunteers, so we kind of can avoid the issue with billing insurance in that way. And I know there are mixed feelings about having groups run by people who are not speech pathologists, but we have well-trained, wonderful group leaders. So it works in our setting. And I think everyone just sort of has to figure out what works best with them. So certainly clarifying with the folks in your organization higher up to make sure that you're following all the guidelines to make sure you don't get yourself into trouble. But, you know, ultimately, we need to provide services for folks who need it. And so I think whatever we can do, you know, within staying, you know, good on all fronts is what we have to do.
Thank you. Another great question here. They said, thanks for a great talk. I'm curious if anyone on the panel uses any specific patient-reported outcome measure in tandem with LPAA approach and whether these tools can be helpful for reimbursement. Anyone want to speak to that?
So I think that question is probably related to like MIPS and the outcome measures in that sense. So we, you know, we're a very small agency, so that in specifics doesn't apply to us. What I can say is that we're constantly, and from an auditing standpoint, as long as you continue to see the momentum and that you are reaching those outcomes, that we're able to advance the goals, either from the provision of caregiver cues or however we're targeting these things. I think that you are able to make those outcomes, although there really isn't anything specific at this time that we can focus on, for LPAA, unfortunately.
Yeah, and just to add to that, if you're looking for a functional assessment that looks at, LPAA outcomes, patient reported, the ALA or the assessment for living with aphasia is a good one. It takes a long time to give the entire test in one, in one evaluation. But you could do each subtest and report a score on that, look for gains. The cattle too, by Holland and colleagues, is another great one. It really looks at specific functional activities. And so that could also help you to report gains as well. And there are certainly other ones out there, confidence scales and whatnot, developed by Cherney and colleagues. So you can look at a number of different ones for patient reported outcomes.
Yeah, and I'm still, I don't know if I should call this old school. I still use a lot of standardized assessments. So I use the Western Aphasia Battery. I use the CLICIT, the Cognitive Linguistic Quick Test, to get some of those number-based that information into those reports as well.
And just another plug for those academic modules in the assessment portion, they have a lot of, patient-reported outcome measures, some data on there. So again, there's a whole presentation on that under assessment, resources on the Aphasia Access model. But we use the ALA as well, and the ACOM and some of those sources as well. But we love the ALA. That has really been very helpful. And then actually we kind of use that in conjunction. The pictures promote discussion, and I use that with the LIVE cards, the life interest value cards, Dr. Katarina Haley cards, and that helps with collaborative goal setting, which is so important as well. So those are just some other ideas.
That's great.
Oh, we just got the Bomba too from Aphasia Institute. I just saw that pop up and I'm like, I just got it in the mail yesterday. I haven't used it yet though.
Perfect. A couple questions here about the use of maintenance therapy and reimbursement, a new buzzword that gets a lot of opinions, they said, and a couple people were curious to hear your opinions on that. Anyone wants to take that on?
I can take that one on. So with maintenance therapy, and again, every agency does things a little bit different, but in my mind, everything has to go back to what is skilled and medically necessary and what can only be conducted by a speech language pathologist. And how we can support that. So if somebody does not have a support network where you still feel that just a touch base, either once a week from an outpatient therapy standpoint, or maybe once every other week, as you start to grade down the severity or the frequency of the interventions, there is a part where you are able to provide that maintenance approach to allow somebody to continue to live well and participate in those items that they would like to. Where I have a hard time and kind of go back and forth, and of course I take this case by case with each clinician that we have and that we work with, is if there is a trained partner, care partner, who can do those, who really understands adaptations, modifications, and can provide the necessary cueing techniques to really assist that client in living well and meeting their goals, then it's a little bit more difficult to continue with that maintenance approach, in my opinion.
That's great, thank you. Would anyone be able to talk about reimbursement for LPAA in acute care? I know it's not really any of our direct settings, but
the one setting I haven't done.
yeah.
Yeah.
I'm so sorry.
I didn't think so, but I wanted to throw it out there. It did come through. My background is more inpatient rehab before Aphasia Center. But I mean, it's not comparable, but in that kind of setting, more acute inpatient rehab, personally, I think, you know, the participation goals are communicating with nursing staff and communicating, you know, preferences on therapy goals and discharge plans and things like that. So all of that can be, it's all participation based and can be reimbursed. You just have to write your goal appropriately.
Yeah.
But I think that would be a talk for another time. It doesn't sound like any of us have direct experience with acute care. One question for Fabi, how do you train? Oh, sorry, Becky. Yeah, go ahead.
Oh, sorry. Yeah, I just, a couple thoughts. I haven't worked in acute care, but talking with friends, I know the challenge is that you don't have a lot of days to work with that person. And a lot of times you're called in for dysphagia therapy rather than actually working on the acute aphasia, right, caused by perhaps a stroke. So what you can do to really meet those LPAA goals, what's the most important? This family has no idea what aphasia is. They're, you know, completely perplexed as to why their loved one isn't talking. Maybe they don't understand the comprehension component. So also really that educational component, have handouts for the family members, have that be a goal. In addition to, they may need basic communication aids just to get their basic communications across, and then they could take those along with them to the next rehab setting. So those would be some critical things to think about in that acute care setting.
Excellent, great points. Fabi, a question for you. How do you train the volunteers that work with you, and how long is that training?
So we provide our groups on a semester-based system. So at the beginning of every semester, we have a 2-hour-long sort of orientation and training session for all of our group leaders. And that includes everything from the basics of aphasia to going through and expressing ensuring, you know, competence and revealing competence. I'm having word finding difficulties. Going through a lot of the sort of underpinnings of what we do, to some basics on how to run groups and how to support our members to the best way possible in developing activities for the groups. And so, yeah, and then I cycle through the groups. So I peek in and give feedback, and we have a weekly group leader meeting. So that's how we all kind of stay on top of it. And we've had so many of our group leaders for years, and you know, they know their stuff. I get to go in and just enjoy. So
that's great. One more question. And I know there's some we're not getting to, so please feel free to email any of us if we didn't get to your question today. But a thought on grants or ways to offset the cost of the free weekly Zoom meetings that some of you have mentioned. Anyone have any suggestions for that?
So I will speak just to sort of one thing that happened with us last year, which was lovely. And as a nonprofit, we do a lot of fundraising, but we participate locally. There's this big raffle that one of the local business owners puts on that all the nonprofits can participate in. And we have a young woman participating in our CAST program, and they have very limited resources. But for this raffle, that family went gangbusters and sold over $1,000 worth of raffle tickets. They came in with a stack of cash. So people can really get behind especially within a nonprofit environment, get behind crowdfunding, essentially talking to family and friends, because they often, like Amora talks about with her CST program, people want to help. And it has to extend beyond, those first few weeks where people want to bring food over after a stroke. It's really, people want to continue to help and they often don't know how. So giving them something very concrete, like maybe it's donating, maybe it's participating in a raffle like that, or, some way helping out. I think that is the benefit of, especially with the groups where there's such a sense of community and people really want to help you help them. So yeah, that was just one experience we had recently.
Thank you. I truly think this is a topic we could talk about all day. And I apologize, we didn't have time to get to everyone's questions, but again, definitely email us. We did just want to end, because this is such a frustrating topic and can be negative. We wanted to end with just some positive thoughts to hopefully, we're midweek here on a Wednesday. So Jody, maybe starting with you, do you have any final thoughts to end the meeting today?
It's just so powerful. Life participation approach has changed my life. I think it's changed people's lives with aphasia. It's all worth it. I know sometimes we can be frustrated with some of the logistics of it, but once you see it in action, you will never go back, and it will it's just so powerful. So just keep pushing forward.
Thank you. Fabi?
Yeah, like I mentioned earlier, I love what I do. I have met the most incredible people, and I don't work just with aphasia, but with a lot of different neurological disorders. And when I think back, like sometimes when I have to review things, I'm like, remember that session? Like I just feel so fortunate to do what I get to do. So certainly the struggles are struggles. And like I said, they're bad days, but I just love what I do. And maybe we need a reimbursement support group or something where we can just cry together. Maybe that's a Wine Wednesday thing, but just, share these frustrations and move forward. But thanks for the opportunity to talk with y'all.
Thank you. Becky?
Absolutely. Thanks everyone for being here, and all of your suggestions that you put in the chat. We'll definitely look at those as well. But yes, I think like we said before, all of us can be advocates. All of us can talk to ASHA about the importance of LPAA and continuing to encourage lobbying, to help with telehealth reimbursement and other important initiatives. We can do this. We just all have to work as a team to get there.
Thank you. And Claire?
I think the biggest thing for practicing clinicians, at least for myself, is if you just take a little bit of time to make your toolkit to get really familiar and the comfort level of applying and making these LPAA goals, then it makes it so much easier to put it into your practice. And I think the most rewarding thing is when my clients say, with this breath of just relaxation of, thank you for listening to me, and thanks for really helping me meet what I want to, try to attempt to do. So it's always rewarding at the end of the day.
Thank you. I think everyone that was here today, we're all here because we love what we do and we love the patients we work with. So I hope that today's talk was able to inspire you, re-inspire you, and just hopefully find some creative ways to tackle these obstacles that we all face. Thank you all for being here today, and thank you for our amazing panelists for sharing your experiences.